dive deep, where minds unravel and health takes center stage. This is the Deep Mind and Health Chronicles with Ahmad, someone MD. A journey through psychology, medicine, and the untold stories of the human condition. Stay with us as we go deep in minds, good in health.
Today we're tackling tuberculosis, its long history, and the very latest WHO treatment guidelines for 2025.
Including that new HPMZ regimen. It's quite a story, this disease. From ancient mystery to, well, something we can actually fight.
And these new guidelines, they really represent a significant step forward, offering hope.
So let's dive in. How far back are we talking?
Oh, incredibly far. We've got archaeological evidence from Egyptian mummies.
Mummies? Wow.
Yeah, skeletal changes, even M. tuberculosis DNA dating back thousands of years BC, and not just Egypt.
Right, you mentioned pre-Columbian Crow too, so it was widespread early on.
Exactly, even potentially in Homo erectus, though that's still debated. It's been with us a long time.
And the written record, does it match up?
It does. Ancient India's Rig Veda talks about yaxma, a wasting disease. China, too, thousands of years ago.
Then you have the Hebrew Bible, Greece.
Hippocrates, yes. Phthisis or consumption, Serenus, Galen, they all described it. It really shows this long coevolution.
So for ages, people saw it, described it, but didn't understand it. What about the Middle Ages?
That's when you get scrofula, the king's evil.
Ah, the royal touch cure.
Exactly. Treatments were, well, pretty basic. Bloodletting, diets, moving to the mountains, based on humoral theory, mostly.
But someone started suspecting it might be contagious.
Girolamo Fracastoro, back in the 16th century, a really important early insight suggesting it spread between people.
Okay, then science starts catching up. 17th, 18th centuries.
More detailed observations. Francis Sylvius spots the tubercles. Richard Morton describes different forms, pulmonary and others.
Gaspar Laurent Bale sees the widespread miliary TB.
Right. And the idea of contagion gains ground. There was a decree in Lucca, Italy in 1699. Benjamin Martin even suggested minute living creatures in 1720.
Ahead of his time.
Definitely. Then Lianac in 1819 unifies the different forms. But the proof, the actual experimental proof of infection...
That was Villemin.
Jean-Antoine Villemin, 1865. He showed you could transmit it to animals. That set the stage for Robert Koch.
Koch, 1882, finally identifies the culprit. Mycobacterium tuberculosis. That's the big one.
Absolutely monumental Nobel Prize work. It explained how it spread.
Yep.
And led to Koch's postulates.
And diagnostics started appearing too. Skin tests, x-rays.
Yes, von Perke and Mentu developed skin tests around 1907. Koch used tuberculin diagnostically, and Röntgen's x-rays from 1895 were crucial for seeing lung damage.
So the 20th century. We know the cause, we can see it. What about treatment? Sanatoriums.
Right. They became common. Hermann Bremer started one in Germany in 1854. Isolation, rest, fresh air, it helped, but wasn't a cure.
The real cure came later.
The revolution was antibiotics. Streptomycin, discovered by Waxman and Schatz in 1943, that was the breakthrough.
And then others followed. PAS, isoniazid.
INH, pyrazinamide, PZA, ethambutol, EMB, rifampicin, RIF. This led to combination therapy. The standard became HRZE for months, a huge leap.
But then a new problem, drug resistance.
The bacteria fought back. Inadequate treatment allowed resistant strains to emerge. First, streptomycin resistance, then MDR-TB, XDR-TB, a major global health threat.
Which brings us closer to today. What's the picture now? 2023 data.
Still challenging. About 10.8 million cases, 1.25 million deaths globally. Southeast Asia, Africa, Western Pacific hit hardest, and COVID-19 caused setbacks.
So ongoing issues with diagnosis, long treatments, resistance, funding.
Definitely. Diagnostics like smear microscopy aren't sensitive enough sometimes, access to better tests is limited, and sticking to long treatments is hard for patients.
But there's progress, right? New tools.
Oh, yes. Rapid molecular tests like expert MTBRF are much better. Point-of-care tests, AI for reading X-rays, even sequencing are improving things. And research into vaccines like M72AS01E looks promising.
And treatment is evolving too, shorter regimens.
That's the big push in the WHO 2025 guidelines. Shorter, safer, all-oral regimens where possible, fewer pills, fewer injections, like a 4-month option for drug-susceptible TB.
Okay, let's focus on HPMZ. What's in that?
It's isoniazid H, rifapentine P, moxifloxacin M, and perunamide Z, designed for drug-susceptible pulmonary TB in adults and adolescents.
And the main advantage is speed.
Exactly. It's a 4-month regimen total, an 8-week intensive phase, then a 9-week continuation phase, taken once daily, importantly, with food.
4 months instead of 6. That sounds much better for adherence.
Potentially, yes. And it avoids ethambutol, which can cause eye problems. Evidence, like from study 31, shows it's non-inferior, meaning it works as well as the standard 6-month HRZE.
Are there catches? Limitations?
There are things to consider. It's actually a higher daily pill burden. The food requirement is key. Moxifloxacin has potential side effects, including heart rhythm issues, so ECG monitoring might be needed.
And it's not for everyone.
No, it excludes pregnant or breastfeeding women, young children, those with very low weight, or risk factors for QT prolongation. So careful patient selection is important.
Okay, so a promising option, but needs careful application. It shows how far we've come, though.
From ancient consumption to tailored, shorter drug regimens, it's remarkable progress.
But the fight isn't over.
No.
TB is still a massive global killer, especially with resistance.
Absolutely. We need ongoing research, innovation, funding, and critically addressing the social factors that drive TB, like poverty and access to care.
So a final thought for you listening. As we get these powerful, shorter treatments like HPMZ, how does that change the bigger picture? What does it mean for fighting not just TB, but other adaptable bugs and the whole challenge of antimicrobial resistance?
Something definitely worth thinking about.
And so, another chapter closes. Thank you for joining us in the Deep Mind and Health Chronicles. Until next time, stay deep in minds and good in health.